Lanka. Oh, no, God, no. This is about each and every one of you being here. So thank you so much. And I want you to continue the conversation. This is about paying it forward. I'm here to give you the information as we have now, and then please feel free to pay it forward, okay? Because just the fact that we're talking about women's health is huge. It wasn't until the 90s that women were actually included in research, which is shocking. So a lot of medication we even take to date were run on men and extrapolated to women. Brilliant. So a little bit about me. I'm a British trained family physician, work at a lovely clinic called Oz Health International. We've got 2 clinics, one at Raffles Hotel, where I'm based, in the arcade at the back, and one in Star Vista, so just here nearby Buena Vista. And it's Singapore's, especially the last year and a half, things have really taken off in Singapore, where the conversation piece, and women are being empowered to have that conversation in the workplace, between friends. It's quite funny when I have new patients come in and they say, oh, my friend saw you and she told me off for not seeing you yet. I said, no, I'm sorry you got told off. And she goes, no, I think I needed a telling off. And so here I am, okay? And also a lot more women coming in saying, listen, I actually don't know enough about it. I'd like to know so that I know what to look out for. And then I'll be able to go, right, actually, why do I need to wait till I'm miserable to do something about it? Let me actually pick up the pieces now. And a lot of it is that foundation when it comes to lifestyle medicine. And we'll talk about that as well. What else? Yeah, I'm a member of all sorts of places. Yeah, in the UK, Sri Lanka, Singapore. And I'm passionate about women's health. So I'm also a medical advisor to a community that's building called SOL, so Spring of Life. And again, it's about empowering women and keeping that conversation going, which I'm really, really excited about. Okay, so what are we going to talk about today? Please ask as many questions. This is very relaxed. I don't normally sit and talk. I like to move around, but I don't think I have too much space going up and down. So we're going to talk about menopause. What is it? Let's debunk some myths, because there's so many out there. I wrote out a list a couple of months ago and for the Osler team, and we're still working our way through it because there's so many. Let's talk about hormones, but it's not just about the hormones, okay? And I know a lot of you will be surprised to hear me say that because I'm a huge advocate for hormone therapy, but it's not just about hormone therapy. Let's talk about alternatives, lifestyle medicine, and healthy longevity. So Singapore is having a bit of a crackdown on the term longevity because a lot of places are using it without quite understanding what it means. So it's really looking at geromedicine. So it's the medicine of aging. So utilizing the terms healthy longevity, geroscience, so the science of aging, geromedicine, but the buzzword is longevity. So it's still there from a conversation point of view. And then I get to give you some homework. So a few resources, if you're interested in reading more, understanding more, if you want to do a course about menopause, it doesn't need to be, you don't need to have a clinical background to do it. It's just understanding more so that you can advocate for yourself and advocate for those around you. So let's start with menopause. Right. What does menopause mean to you? Shout it out. Tell me. Sorry? Disappear. Oh, despair. Oh, come on, bit more positive. Let's go. What does it mean to you? No more period. There you go. Bit of a positive one there. Anyone else? What does it mean to you? Liberation. Yes. I'm gonna have to give you this seat here. Yeah, and it means different things to different people, right? Whether you're going through it, whether you're not, whether you've been through it, whether you're yet to go through it. It is very individual. Now, the reason I've mentioned from an age point of view, because technically, menopause is when your period stops. But in order to know that it's post-menopause, the guidelines are 12 months with no period. The average age of the menopause globally is 51. So that's really Caucasian women. For Southeast Asian Singaporean women, it's 49, so 2 years younger. And for South Asian women, especially living in their country of origin or in the APAC region, it's 46 or 47. So when I have women coming and saying, oh, my doctor has told me I'm far too young to be in the perimenopause, the perimenopause is the time before the menopause. And that can be on average 6 to 8 years, but anywhere between 5 to 15. So there's no such thing as, it can be too young. There's also the impact of early ovarian failure, so where the ovaries fail at a young age for various reasons. It can happen, we don't know why. Can be trauma, can be cancer, chemotherapy, radiotherapy, certain medications. And under the age of 30, it can happen in 1 in 1,000 women. Under the age of 40, 1 in 100. Those aren't very high numbers. So it's about not just assuming everything is perimenopause related. And I know with social media, everything is, I'm in the perimenopause. Okay, hold on a second. Let's look at what else it could be. Let's rule out those organic causes. And that's why for me, being a family physician, I'm just in the best position to look at things in a 360 way, which is great because I'm not looking at it, oh, I'm a gynecologist, so I'm only going to look at it here. Oh, I'm an endocrinologist, I'm only going to look at it here. I look at it in that 360 way, which is why for me, women's health needs to sit in general practice in primary care. I'm also a British doctor, so when the NHS, it's all about we're the gatekeepers of our patients. We're very protective of our patients. You only get to see a specialist if you absolutely have to. Also, there's such a long waiting list that you've got to wait a year to see a specialist on the NHS anyway. Okay, so let's talk about a woman's life in hormones, right? Think of this actually as squiggly lines, especially in this sort of middle part. So we have our steady state of hormones, but then in the perimenopause, it starts to drop, but it's not just dropping, it's going up and down, up and down, up and down. So I have a lot of women who say, I'm booking in to see you, but then I felt okay, so I thought, actually, no, I'm fine. And it might be a day, 2 days, it might be a couple of months later, they're going, oh my goodness, I'm back at rock bottom. And then they're back up again, and then down again. And that is exhausting. Because if you think you're in this constant fight or flight response, you're either running away from a bear 24/7 or you're fighting a bear 24/7. That is exhausting. Plus, you're probably in a sandwich generation, looking after aging parents, looking after kids. Who's looking after you? So this is where you'd be a little bit selfish to care for yourself. We are at a gym, so let's talk a bit of exercise and menstrual cycle. Really, really important. Because as women, we can actually optimize our training when we have a period, when we have a bleed, we have a cycle, or even if you don't, you can create your own cycle for you, right? So say, for example, you're postmenopause, or you've got some sort of contraception, implant, injection, or Mirena coil where you've lost your period, you can actually create a 28-day, 30-day cycle for you. Use a full moon cycle, full moon to full moon. Use the monthly cycle, use the month from the first of the month to the end of the month. So the first few days, that phase 1 is when all the hormones come crashing down, but you actually feel so much better. That's when you have your period. Then comes the hormones, your estrogen and testosterone, starting to peak, coming up to ovulation. That's where you can really optimize your exercise. So hitting those personal bests, really maximizing your muscle mass, your endurance side of things, and you have energy. You know you can hit it, you can do it well. At ovulation, if there's no pregnancy outcome, right, then the hormones start to drop a bit, but then the progesterone goes up. But if you're not pregnant, that progesterone comes crashing down. There comes the PMS. Everyone knows what PMS is? Yep, your premenstrual symptoms that come just before your bleed. Progesterone is our calming hormone. So when that comes crashing down, feel pretty low, pretty terrible. Estrogen is our get up and go hormone. So it gives us that energy, that oomph. And testosterone works to optimize our brain function, that brain fog side of things, muscle mass, and a lot of the sexual health dysfunction that can come as well. So this is where that first part of the cycle, you can really push yourself. So maybe the first few days of the period, a little bit harder, so you take it a bit easy. but then you can really push yourself and optimize things. Then coming towards that 7 to 10 days before the period is where you take it easy. You look at more of the yoga, the Pilates. If you're training consistently, don't try and go for PBs. Stick to your maintenance. Yeah? And then the cycle starts again. And you can create this for you. So a lot of athletes, it's very hard to plan a race around your period. Okay? But you'll see that their performance in general will be better depending on where they are in their cycle, or changes depending on where they are in their cycle. Yeah? So my background is tennis, and you can see it, and I know it, and there are a lot of, the British team that I follow who are also friends, and you know it, and you know from them conversations where they are, and there are things you can do. So that recovery piece plays a huge part as well. So the book I've mentioned is called Fast Like a Girl. Now, in the perimenopause and menopause, it's a little bit harder to fast. Mindy Peltz is an American nutritionist, does a lot of functional work. This graph, this table, it actually is from her. Am I the biggest fan of long fasts in the perimenopause? No, just because it's very individual, right? However, this part of her book is fantastic. So it's a good one to read, and she does various protocols and things, and I have patients who swear by it. But again, it's very individual. So it's not just following suit because it's going right. What works for me and what is sustainable? So this is just a little bit about what the perimenopause is, what menopause is, what postmenopause is. What I really wanted to show you were the numbers. At any given point, there's 1.34 billion women in the perimenopause and menopause. That's a lot of, it's a lot of people. Look at it from then, if we look at it from a corporate point of view, a finance point of view, 10 billion loss in earnings. So the impact on the workplace, the impact on families, and personal impact as well. So I'm going to start with the study. It's called the SWAN study. So this was in the US, but it's sort of the study of women's health across nations, meaning Caucasians, African Americans, non-Mexican, Hispanics, Chinese Americans, and Japanese Americans. And they ran this study. So it's a longitudinal study. So they ran it over years, and they kept pulling all the data. So from about 1996 across 7 various medical institutions, really looking at the misunderstandings and debunking myths. So memory loss, pain during sex, vaginal dryness, and depression. 2/3 of menopausal women have memory complaints. How are you supposed to function? Right? That multitasking is what we were built for, right? When you lose that ability to multitask, and then suddenly that safety net you have has holes in it, how much can you actually catch? How many balls can you juggle? How many balls can you catch? The other commonly held myth, and I had to put this in because it made me sort of smirk, is women need to keep having intercourse to prevent symptoms of pain during sex.
That's what a man said.
Thank you. There we go. What did I start with? Research for women only started in the 90s. When it comes to sex, it is very important, but it should come down to choice. I don't want women to turn around and say, I don't want to have sex, because actually it really hurts to have sex. You choose not to have sex because you jolly well don't want to have sex. Okay? But it's about choice, and there's lots of things we can do. Doesn't mean as we get older, oh, sorry, sexual functions down, that's it, we don't need to do anything about it. Okay? He sat right there.
This is where most of the marriages fail.
Correct.
All the partners
Yeah.
stop helping female out and then
Yeah.
leave them alone.
Yeah. Yeah. So 7 out of 10.
Yeah.
That's right. He gets very fed up with
Yeah.
going on about it.
Testosterone. Yeah. And actually, there was a study done in the UK a couple of years ago where looking at women, couples going through divorces, 7 in 10 women said perimenopause played a part in it. That's a lot. Yeah. Okay. And then poor sleep as well. For me, sleep is number one. If we can correct and optimize sleep, and as adults, we should be getting 7 to 9 hours of sleep every night. Put your hand up if you actually get 7 to 9 hours of consistent sleep every night. Yeah? A little bit, I'm there, nearly there. Yeah. When you sleep, everything else falls into place, and you can really build on everything else.
6 hours?
Singapore. We have data in Singapore now as of earlier this year. Okay, so this was done actually at the National University of Singapore by Dr. Susan Logan and the team there, and she's a lovely, lovely doctor who's unfortunately had to go back to the UK. She's gone back to Scotland. So this was looking at really a survey, and it's something I'd love to actually run amongst our patients at Osler as well. So 1,200 women, and running this survey, Q&A, going, okay, let's try and get some data and track it, especially for women in Singapore. So looking at osteoporosis risk, sleep apnea. So that's where snoring. So I know we talk about it in men, but actually sleep apnea is really common in women as well, a lot more common than we think, which means it wakes you up, you're not getting enough oxygen, it interrupts your sleep. Depression, anxiety, loss of bladder control, right? Very common. Here we go. We've got physio sat right in front. Very, very common. Okay? And it's the impact it has on that, the increased risk of urinary tract infections, the embarrassment. Then it curtails your social activities because you don't want to be out or doing something because that may be embarrassing. Sexual health, vitamin D deficiency, chronic diseases. Who feels that breast cancer is the #1 cause of death in women? It's heart disease. It is not breast cancer. And that's really important to know. So under 50, men's heart health risk is higher than women, but post-menopause, women are at much higher risk of heart disease than men. And they've even brought in sexual health, which I was really, really happy to see, because it can be a bit of a taboo subject in this part of the world. So this was the paper that actually came out of that. And I wanted to break it down a little bit, looking at it from a ethnicity, cultural point of view. So Indian women are more likely to experience moderate to severe symptoms. I have a huge guilt I carry with me, and I always will, because in the UK, as doctors, we see what's called all-over body pain. And we scoff and laugh at that because it's your Bangladeshi women, Nigerian women, Indian women, Pakistani women, where English is not their first language, and all they can tell you is all over body pain. And we did nothing for them. Right? And looking back, we ruled everything else out. You can top up vitamin D till, till sunrise to sunset, but it's the perimenopause, and it's managing that. But when you have that language barrier, and then it just becomes this everything hurts doctor, it's where do you start with that, right? Yeah.
A lot of those
Yeah.
patients are sent to chronic pain clinics
Exactly, yeah.
instead of addressing the
Yeah.
perimenopause at all.
Yeah, yeah. Because it's just not something that we would look at. Yeah. Then Malay women reported higher urogenital and depression scores. Chronic medical conditions associated with severe symptoms. And just yesterday, I had a conversation with the patient saying, can you see my mom? She's still having hot flashes. I said, absolutely. But she's postmenopause. I said, yeah. This is what we see here, and this is the difference, is those hot flashes are not a #1 symptom in this part of the world. Right? It's those joint symptoms, and I'll go through all of that. But the hot flashes, those vasomotor symptoms, can really kick off after 55 and 65. Yeah. So how does menopause affect our body? It's head to toe, right? But that musculoskeletal symptoms, sleep issues, pelvic floor, urogenital symptoms, brain function, skin, and the impact on heart and blood vessels. I haven't even mentioned hot flushes there because it's at the bottom of the list. So I have some very surprised women who say, oh, but I don't have hot flashes, so I'm fine. I said, well, hold on a second. It's not about the hot flashes. It's actually, it's hot in Singapore. Nobody knows if they're having a flash or not. Which is why I've highlighted these key areas. So your physical and mental exhaustion, issues with sleep, And joint aches and pains tend to be right at the top of that list. Sleep disturbances, those vaginal symptoms, and these are things we can manage pretty well, pretty easily. So a couple of books, so Dr. Louise Newson, that I'm doing some work with as well, and Dr. Lisa Mosconi, who I'm a huge fan of, and she's lovely, right? Because the two of them are actually doing the work that's needed by cutting out the noise. So there's no pharma involved. It's about information, data, and progression, and giving women the best chance of optimizing their health and well-being, which is huge. Yeah, and that for me is gold. That's why I spend a lot of my time, in my own time, doing these education work, is because I want to be able to get that right information out. So further myth busting. This is not an old lady condition, right? I had to put it in there, okay? And 25% of women actually have little to no symptoms, and they just get through it. They wake up one day, I know, I tell these women, shh, or don't go into too much detail, but maybe say, here's what I've been doing, and it sort of works. So I'm looking here because we were talking about no symptoms. She breezed through it. Yeah. Managing it, exactly, and that's that lifestyle piece. Yeah. And body identical hormones are safe and effective, right? So there's a lot of sort of old wrong information about hormone therapy. What we have now is as close to the body's own hormones, and it works really, really well. Question I get a lot of the times is, oh, I need to get my hormones tested, doctor. Don't need to, okay? Again, I have my NHS hat on. I like to save people some money. If you need a test, you need a test, okay? But the issue with hormone testing is I can poke you hard enough and those hormone tests change. You can be at different parts of your cycle, and I've run all these tests. There's a whole bunch of us who do, where you can run a blood test every day for your entire cycle, repeat it twice over, so you have 3 sets of data. You can compare your day one to day one to day one, and it's different. So there are instances where we do test hormones. So if you're under 40, if the diagnosis is unclear, if you've got a Mirena coil and we don't know where you are, or you're on contraception, like the implant, the injection, progesterone-only pills, where you're not getting a period, then it would be good to know where you are. It's also knowing your baseline testosterone, and that's important to know, okay? But otherwise, you don't really need to do blood tests. A lot of functional medical specialists do, but that's part of what they do, which is fine. And I work with a lot of them, and I will say, right, here's how you do things. But at the end of the day, what we come down to is how do we get our patients sat in front of us to have the best quality of life, okay? So it's just looking at that person as an individual. Where tests can really play a part, and I'll give you an example. I have a patient who moved from Hong Kong, and really stressful move, had kids here, and she was recommended by a friend and colleague in Hong Kong. And she said, oh, you know, I've been on hormone therapy a good few years now, but I think I need to up my dose. So I said, okay, why? What's happened? And she said, just not working, and you know, my symptoms are back. And it just didn't sit right, because for somebody who's been on steady hormone therapy, for something to just change like that, it just didn't hit right. So I said, okay, can you think of anything that changed? Did you have an infection? Anything? No, I'm fine. I said, did you notice any, you know, swelling in your neck? No, nothing. Okay, fine. Do you mind? Can we just get a couple of blood tests done? So I wanted to check her thyroid function in particular, because thyroiditis, which is inflammation of the thyroid due to an infection, can throw your thyroid function out of whack, medical term there, which can be very similar to perimenopause symptoms. And her test results came back, and she had an underactive thyroid. So when I went back and I said, okay, think again, come on, go back, 8 weeks, go back. She goes, actually, I had a sore throat, but I was fine. Actually, no, you're right, maybe my neck felt a bit swollen, but I felt okay, so I just carried on. So we corrected her underactive thyroid by giving her some thyroxine, and not even a couple of weeks, she goes, God, I'm back to normal. Now, the easiest thing would have been just to keep going up on her hormone therapy, but this is where, you know, and I'll keep going back to this, the beauty of being a general practitioner, family physician, is you can really think outside the box. Yeah.
So with thyroxine,
Yeah.
in that instance, would you have taken her back off it once it got back?
Yeah, So she'll be on it for about 3 to 4 months, and then we.
Lifelong condition is a
So it depends. If the thyroid just doesn't function for you, then it's lifelong. But thyroiditis is inflammation of the thyroid due to a virus. Once that settles and calms down, you can come off it. Yeah. So in January, February time, I will have her on a trial of her thyroxine and see how she does. Yeah. Yeah. If her body says, actually, no, I need it, then she'll be on a small dose long term. Yeah. Yeah. Pleasure. No, not at all. And okay, Mirena coil. Who knows what a Mirena coil is? Yeah. So this is the only contraception. So it's a little coil that sits in the womb, and I do them in the clinic. It works as both as contraception, but also the progesterone component of hormone therapy. So it's the only one, because hormone therapy is not contraception. I want to make that clear, okay? So it is not contraception. Yes, you can still get pregnant on hormone therapy. The chance is less, however, we still have to mention that. But the Mirena coil works really well because it's a little bit of progesterone that stays pretty locally, keeps your progesterone level nice and steady. And then when it comes to hormone therapy, if you still need something, a little bit of estrogen, either in the form of a gel or a patch, plus or minus some testosterone. So that's important to know. And also, there's a lot of information on complementary therapies, right? I know a lot of doctors who go, ugh. I say, hold on a second. We've had TCM and Ayurveda, for thousands of years before Western modern medicine came to play. The difficulty is we don't have studies with direct comparison. So it's quite hard to know. And it's also knowing how clean all the herbs are and the products. So in the UK, we have the traditional herbal registration logo, THR, and at least then you know, okay, this is monitored in a sense, right? It's also from a supplement point of view, supplements are unregulated in Singapore. So in Australia, they are regulated, and we are now looking at a company that's trying to get it regulated here, their products regulated in Singapore, so that we actually know what's in it and the impact of it. So it's just, again, looking at that overall picture. Okay, hormone therapy. So what is hormone therapy? It is simply trying to change from hormone replacement therapy, because I'm not replacing anything. We're not replacing anything. It's simply giving back what the body needs. So we're switching that terminology to menopause hormone therapy or just hormone therapy. And it's really primarily used to manage symptoms. But it's also the benefits we don't see: optimizing heart health, bone health, brain health, reducing the risk of chronic diseases, and reducing the risk of some cancers, including colon cancer. And in women without a womb, where they're only on estrogen, it does reduce the risk of breast cancer as well, okay, which is huge. So we have to start thinking outside the box, and this is where the last part is going, where are we going in the future? And that's my most exciting part, is future of medicine, okay? Different types, combinations. I try and stick to anything that's through the skin, because then it avoids what's called the first pass metabolism through the liver, which means that increased risk of blood clots is negligible. It's technically non-existent, but it's medicine, so we can't say that. But it also helps from a gut health point of view, because things aren't having to get digested, it's getting absorbed. Which clinics? They should be, yeah. So hospitals have specialist clinics that you have to go to.
Actually,
Yeah, yeah.
they don't recommend this. They stopped completely about a few years ago. I could only get those tablets only in private.
I'm sorry to hear that. That's not something I've heard, because I have a lot of women who I do send them, especially Singaporean women, because from a cost point of view as well, it's just access-wise, locally, like we have to get a special license to get a lot of these hormone therapies in. So in the polyclinics, I don't think would issue it, but like KK, Tantosen, their women's health clinics, their menopause clinics do prescribe. Yeah. But we can have a look at it together after. Yeah, okay. And then, so osteoporosis, cardioprotection, etc. But how do we know? Remember I said earlier, you don't need blood tests. So how do you know if you need hormone therapy? And that's a question we had earlier as well. So I like to use what's called the menopause symptom questionnaire, okay? We have over 70 symptoms we can attribute to the menopause. I know, sorry ladies. But these are some core symptoms, and this is what I like to track, because I tell my women, you know yourself better than anyone else. Don't let anyone tell you otherwise, including me. I am here to listen to you. Let's track the symptoms and let's see how you're doing, right? If something's working, great. If it's not, we go back to the drawing board and we tweak things, we work things out. So it's not used to diagnose, it's used to track. So that way we have a baseline and then we go from there. So technically, if you score above 15, 1-5, and we rule out organic causes, then it warrants a trial of hormone therapy. And here are the options, right? The reason I've highlighted anything sort of through the skin, oral progesterone. Now, I mentioned earlier when we try and avoid things orally, this is called micronized progesterone or eutrogestin. So yes, it's a tiny little white ball, but you take it orally. It can be used vaginally as well. It's also used in pregnancy if somebody's pregnant woman's cervix is too short and it needs lengthening to support the pregnancy. We insert it vaginally, so it's safe to use in pregnancy. Is you take it orally, but it gets dispersed into the body. So it's micronized, which means that it reduces the risk of it going to your liver and into your gut. It also works really well because it's sedating. So sleep makes a huge difference. I have women who have the Mirena coil, where I still have to use a little bit of eutrogestin because the sleep factor still takes that little bit of time. Okay? So again, it's very much an art rather than it just being, here's a number, here's how much you use, here's your number, here's how much you use. So that building that relationship with patients is really, really key. Okay? And not forgetting vaginal estrogen. This is something that women who've had cancer, have cancer, can use because it's very, very local and the dosing is tiny. So as an example, if you slap on one patch of estrogen or you use one sachet of gel one time, the dosing is the equivalent of 1 year's worth of Vagifem. Okay, so that's how small it is, right? And I have a few patients actually who've had breast cancer and other types of cancer, and we've safely got them on Vagifem because at the end of the day, it's about that quality of life. And also different ways of using hormone therapy. So I'd mentioned earlier sequential versus continuous. Sequential or cyclical is when you still have a period. We don't want you to just lose it because your body is still functioning. It's got its own ovarian function. So we create a cycle where you still have your bleed. But if you're bleeding every few months or you haven't had a bleed, you're post-menopause, then you can be on continuous hormone therapy. Okay? So again, it's looking at the person as an individual and creating that plan for them, and we can change it at any point. The beauty of hormone therapy is if you stop it within 2-3 days, body identical hormones are out of your system. So it's out of sight, out of mind. So that first 3 to 6 months is simply a trial, which is good. So breast cancer and hormone therapy. My real take home from this is 1 in 7 women in the UK and 1 in 8 women in the US will get breast cancer whether they're on hormone therapy or not. Hormone therapy used in the form of the newer hormone therapies we have does not increase your baseline risk of breast cancer. However, what does is if you're obese, if you smoke, and if you drink more than 2 glasses of alcohol every day, sorry, not saying don't drink alcohol, make it a good glass of red wine. However, this is where the data is. So it's putting it into context. Right? So if you're worried about something's going right, what can I do first? And then how do I optimize my quality of life? Okay? And also from a family history point of view, even with the history of genetic risk or personal risk. And similar with blood clots and heart disease. So once upon a time, we said if somebody's had a blood clot, they cannot have any form of hormones. That is incorrect now. Because the risk from newer body identical hormones, especially, we worry about estrogen, right? But estrogen through the skin doesn't increase it. And the progesterone, if it's the micronized progesterone, we have no known increased risk. Now, this may change in the future, but so far, the data says otherwise. And it's about following the data. And I'll be more than happy to say, listen, here's the data I followed, and here's where it's progressing. And then to be able to change my mind and be able to say, right, but here's where the data is. I want to do the best for you. Here's where it's going, and this is where we'll take it. The research we have currently is hormone therapy being started in the perimenopause, which is where we see the biggest impact, or within 10 years of the menopause, especially under the age of 60. But I have women, especially British women, who are here. They had their 5 years worth of hormone therapy that they were loved on the NHS, and then for the last 10 years have been miserable. And I get them on a little bit of, this is where I go for the lowest effective dose. Normally in the perimenopause, you're optimizing things because that's where the benefit is. But post-menopause, it's looking at managing symptoms for the quality of life. So it's looking at the lowest effective dose for them and keeping an eye on things. As I said, quality of life. And I'll say that time and time again. So there are other treatments. So tibolone is very much used here in Singapore. Am I a big fan? No, I'm not. It's called Liviol. It's synthetic. It's got components of estrogen, progesterone, testosterone, but it also fights your own natural hormone receptors, which is why it's actually licensed in the post-menopause only and for up to 2 years. Because if you use it in the perimenopause, it's fighting your own natural hormones, and I have women who feel horrible. And there are some doctors, unfortunately, who have been using it in the perimenopause, and it really does throw a spanner in the works. Because women just feel like their body is just constantly fighting themselves. But it has its place, okay? And there are women who say, listen, I just don't want hormone therapy. Okay, here are your options, right? Choice, it's about choice. And non-hormonal. So non-hormonal, I almost think of these as just symptom management, so almost bandages, right? So if you're looking at managing hot flushes, joint aches, pains, we've got things like gabapentin, pregabalin. You may have heard of this from a pain point of view, so if you've been part of a pain clinic. We use pregabalin in low doses as an antidepressant, anti-anxiety as well. Clonidine is actually an older anti-blood pressure, so hypertensive medication that is licensed to manage hot flushes. I haven't used it. Used to be used quite a bit once upon a time, but just not used it in the last sort of 10 to 15 years. And then low-dose antidepressants. So not being used as antidepressants, but being used to manage all the surges in that conversation, the neurotransmitters, the conversation between the brain and the gut. Our guts account for 70% of our function. So we really need to look after our guts. Now, Vioza, I've started because, again, it's very new. Big pharma, lots of money being thrown at it. It's technically licensed only to manage hot flushes. So it works on the thermoregulation center in the brain, but it's just very, very expensive. And to be honest, we're not getting to the root cause of the issue, but it's there for a handful of women who just can't have anything else, which is fine. And herbal. So this is where sort of most studies are inconclusive, but in the UK we have the THR logo, and it's just from an interaction point of view. It's also a lot of these herbal preparations will have the phytoestrogen component, but not the progesterone component, which then means you're having more estrogen in the body, but no progesterone to protect the lining of the womb. So then you can get that irregular bleeding and changes in the lining, which in the long term could potentially result in changes in cancer. So this is where it's just finding what works. Now, where we really do have evidence and is sort of that mind-body therapy. So CBT, cognitive behavioral therapy. Should it be first line? No, it should not, but it's there, it plays a part, and it comes down to that overall holistic view of managing symptoms and managing the person in front of you, right? Mindfulness-based stress reduction. There are over 800 courses. A lot of them are free. And I do mention this especially in sort of in the corporate world and to HR teams, saying this is something you really need to offer your employers. And it could be something that you bulk buy and have that on offer. And yoga, acupuncture, lots of evidence there. Okay, so looking at that real 360 way. Ooh, Healthspan. If I said Healthspan, what does that mean to you?
Able to move like now.
Yeah.
Regardless of age.
Yeah. Yeah. Anyone else?
Combination of lifespan.
Yeah. Together? Okay.
Working together.
So longevity is the sort of buzzword. Longevity is lifespan and health span. Lifespan is the age we live until. Health span is the age we are healthy until. Unfortunately, the gap between the two is 10 years. I don't want to be unhealthy for the last 10 years of my life. I want to be healthy, 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 drop dead, hopefully on a tennis court. Thank you very much. And done. Right? Give me a solid 80 years, I'm happy. The issue is that gap is what we need to bring together. Okay? And the way we do that, actually, it's exercise, but the right kind of exercise. So we were talking earlier, it's optimizing your muscle mass, optimizing your strength, which in turn builds your endurance. And the work we do now sets us up for 20, 30, 40 years ahead. And this is the exciting part of menopause. So I want to talk about the future of menopause care. So actually, this study just came out, and I was doing my sort of research over the weekend I like to every couple of weeks just go, right, what's the latest, what's happening, let me add that. This literally just came out. So luckily I did my extra research on Sunday. I would have missed it on the Saturday. But it's a role of menopausal symptoms on the future of health and longevity. When should we be managing menopause? Should we be starting before symptoms? Should we be starting only when there are symptoms? Do we need to wait until the symptoms are bad enough that people, the benefit outweighs any risks of hormone therapy? And this is where the studies are happening. So menopause symptoms are highly associated with the future of health and longevity. Why? Similar to now vaccinations, in the menopause, we're in an inflammatory state. The more inflamed we are, you would have heard of inflammaging, our aging process happens further. It changes our epigenetics. Epigenetics, it's basically we've got our genes and we've got our telomeres, which sit at the top. These get shorter as disease comes into play and we get older. Whereas exercise, for example, makes them longer. The longer our telomeres, the healthier we live until, which means we shorten that gap between lifespan and health span. This is not about living till you're 100. You want to live till whatever age you live till and be solid, okay? Cardiovascular disease, psychiatric disorders, diabetes, and bone density, reduction in bone density are major risk factors. So osteosarcopenia, loss of bone density, loss of muscle mass, it's a huge problem in this part of the world, right? Which then leads to frailty. One fall, you fracture your hip. Any falls over the age of 65 increases your risk of death by 4 to 5-fold, even more depending on your other chronic conditions. And actually, it's essential to assess whether treating menopause symptoms as they arise could actually influence. So this is where now this new data will start going, and we'll do this longitudinal study where over the next 20, 30 years, we'll start to get more and more data. But hormone therapy is actually being looked at as a longevity drug. So it might be that it's just thrown in the water in the future. I don't know. We'll see. Okay? So I just want to quickly talk about the 6 pillars of lifestyle medicine. I'd normally go into each and every one of these in detail, but I want to focus actually on exercise. However, for me, number 1 is sleep. Okay? So we've got to optimize that sleep. Number 2, nutrition. Protein and fiber. Protein. This isn't about eating a whole chicken every day, ladies. Build it. Whole food, plant-based. Use your topping as your chicken, your fish, your prawns, etc. Right? But there are plenty of vegetarians and vegans out there who very much hit their protein targets. Wholesome food, not preservatives. Yeah. This isn't about going, oh, I don't have time, so I'm just going to have a protein shake. Protein shakes, protein powders play their part, but it's not as an alternative to your food. So really looking at that food. My 3 go-tos, Greek yogurt, cottage cheese, tofu. Okay? It's a bit of a love-hate relationship with people and cottage cheese. Doesn't taste of anything. Throw it into everything. Gives you easy protein. Okay?
Blend it with some sun-dried tomatoes.
There you go.
And jalapenos, make a hot dip, put it in bread,
Look at
have
that.
it. That's it.
There you go. Next talk, we're having cottage cheese dips here. Number 3, exercise. This isn't about going for massive runs and doing all these big HIIT workouts. HIIT plays a part in small doses, but otherwise it puts a lot of pressure on the body, your thyroid, cortisol. You've got to lift some heavy weights, ladies, okay? That is so, so important for that strength, for that muscle mass, and for that endurance. And then with these three come your mental health and well-being, doing things socially. And then if you smoke, stop smoking. If you drink, make it count. So moving on from that, what negatively affects your actual biological age? All of the above. But what is biological age? So chronological age is what your birth certificate says. Biologic age is what you think now. Biologic age is if you were to actually test your epigenetics, either from a blood test, your gut health, it's what your inner age actually is. And what we should all be aiming for is for that to be a lot younger than it actually is. I was laughing earlier and saying, I'm 22 for life, no matter what. So you may age, but you never get older, right? And it's that mindset as well. But also looking at what can I do to really bring that down. And it's strength and conditioning, it's exercise. It plays a huge, huge part. There you go. There you go. Yeah. Oh, you beat me as well. Need to have a chat. Yeah. Okay. And there are lots of tests and checks you can do. Now, right now, these tests are on the expensive side. I'm hoping at some point it just becomes more accessible. And it's getting there. But it comes down to that data point and knowing your numbers when it matters. But it's also not getting stressed out by it. I have a lot of patients who wear lots of tech. I love to wear anything and everything because I like to test it on me, because I understand it, I know what I can do with it. Sometimes when you look at data, and it's really stressful because your Garmin, your Apple Watch, your Whoop, your Aura Ring's telling you how stressed you are and how rubbish your sleep is, and that's not what you need to hear every day, right? So it's putting things into context. Right, let's talk about medical interventions for aging. So it's about treatment and prevention, options of hormones, personalized risk factor-based use of medications, looking at older drugs, metformin, right? There's a big trial called the TIME trial going on at the moment, and I'm waiting for it to finish because it's never ending. I'm on a longevity group with the main scientists there, and everyone goes, come on, where's the data? But yeah, we've got a lot of information there. Then other diabetic drugs, so SGLT2s, GLP-1s. So GLP-1s are your Ozempics of this world, right? So it's being used, and I've been prescribing diabetic drugs for a good long time because I have a special interest in type 2 diabetes and run a specialist clinic in Westminster in London with it. So I have that data for a long time, and you can see that the risk of heart disease actually is less. My diabetics on metformin had less risk during COVID from catching COVID-19, than others who weren't on metformin, whether they had diabetes or not. So we have that data set. And then rapamycin, don't have it in Singapore, but rapamycin is, we have to be a little careful, right? We have a lot of data on it. It's used, we have to keep an eye on kidney function. But a lot of, in the US, these things are used because it's private healthcare. But we just have to make sure things are monitored in a safe and effective way. It's also looking at new technologies, so stem cells, rejuvenation therapies, and then older technologies, your cold therapies and saunas, and also supplements. But please do not go spending money on supplements until you talk to someone who actually knows what they're talking about and personalizing it to you. Again, I'm going back to whole foods first, please. Supplements are your little sprinkles on top. So don't just go, ooh, look, that popped up on my social media, I need to get that. Or my friend is taking this, so let me go buy that. You could end up going down quite a rabbit hole. And I'm a big fan of iHerb, but you don't need to just spend money on for the sake of spending money. So this is the chronological age versus biological age. So what can we do to actually make our inner selves a lot younger than what our actual calendar age is? So protein and fiber, regular exercise, not smoking, moderating alcohol, and managing stress can really slow things down. And a few ways of testing it, so blood and gut. So metabolism and aging. So this is really, really important because we need to look at our mitochondria, and a lot of this comes down to that exercise piece. So how higher metabolic efficacy is actually linked to better health outcomes as well as the mitochondrial function. But we have to look after ourselves. And this again comes down to what you can do that is sustainable for you. It's very easy for me to say, oh, you need to do this much exercise. Here's how much strength training you need to do. But if you're not in a position to do it, you can't force it on you, right? So it's looking at what is sustainable. I am not a fan of BMI, right? Because it just misses out so many key things. Our gold standard of actual body composition right now is a DEXA Fit scan. So it is a low dose X-ray, and it breaks it down into your sort of skeletal muscle mass, your visceral fat, your body fat percent, and then I call it the 3-in-1 because you get your baseline bone density as well. So this is a good baseline to do. There are lots of machines that we use. I know you guys have a really nice one. In body here, and then the big one is at Raffles. But whatever machine you use, continue to use that machine, right? Because that way you can track it, and even if there are little variations, in body, for example, overestimates your overall body water content. But if you're using that same machine, then it's comparing like for like, right? And make sure it's
We don't understand the ECW, which is extracellular water in the body.
Correct.
As a female, we retain a lot.
Yeah.
And then anything, even you inhale 2 times, it will gain weight because
Agreed, yeah. You watch your partner eat and you gain weight. Yeah.
So, as Dr.
Yeah.
Tash said, we need to connect our brain to our gut,
Yeah.
and then understand why we have put on weight next morning and we are feeling blah and bloated. So our body tells it right away. So we are the one who neglected to understand and read the signs. So once you connect these two, you will be healthier and stronger, and then not put on weight, and then reduce the body inflammation.
There is no reason why you can't manage your weight in the perimenopause, okay? Unfortunately, what happens is our hormones, estrogen, progesterone, testosterone, are created from fats, from cholesterol. So when the body is going through these massive ups and downs, the body goes, oh, hold on a second, I need to deposit more fat to try and get the body, get the brain to go, right, come on, create more hormones. Where does that fat get deposited? In all the right places. Hence where protein, fiber, so sleep, protein and fiber, and strength training, because you're converting that fat to muscle. When your hormones go into your fat cells, it's actually quite hard to get it back out. Whereas with your muscle mass and that metabolism that comes with it, your basal metabolic rate, can optimize things. Okay? Little bits and pieces here on strength. Really looking at what your goal is. Is it gaining muscle or gaining weight by gaining muscle? Are you maintaining? Are you trying to lose weight? So you have to look at it as you as an individual. And unfortunately, as we were talking earlier with weight loss, sometimes you can't choose where that weight goes from, right? Lots of extra bench presses coming, especially across the chest. So types of strength training. You've got your resistance, you've got your body weight training, your weightlifting. Now, if somebody's never lifted weights, you start at home with some body weight exercises, right? Especially in Singapore, it's not cheap. We know it from a personal training point of view, gym point of view, but it doesn't mean that you have to just go from 0 to 100. You start at home. There are lots of free videos online. Joe Wicks, just lots of free things you can do on YouTube. Do it as a family together. And little exercise snacking, especially if you're working from home. When your kettle's boiling, do some push-ups, hold a plank, hold a wall sit. There are little things that you can do and build that up. And then really for strength training from a longevity point of view, it's that muscle mass. It's maintaining that muscle mass. But you can't really maintain muscle mass if you're not fueling the body right. 80% is nutrition, I'm afraid. And then key concepts. So this is really going into a little bit of jargon because I just love it. And I think especially if you're in the gym, you'll know a lot of these terms. Your 1 rep maxes, your rate of perceived exertion, your RIRs, and then what does it mean practically? So when we talk about lifting weights, especially to build muscle, it's going to heavier weights, but lower reps. But do it safely, right? Don't suddenly pick up 20 kilo dumbbells expecting to do very much with it. It takes time. So you build it to you. It might be you start at 1 kilo in each hand. Go for it. You build it, you build it, you build it. But incorporate that strength work, because strength is what will keep us going as we get older. What you don't want is to have a fall and then be sat there for 2 days until somebody finds you. When you fall, you want to be able to pick yourself up. When you're traveling, you want to be able to pick up your own suitcase and put it up at the top. You want to be able to carry your shopping, your groceries, and be able to put it away. You want to be able to get up when having been sat down. So it's the practical applications there. Now, one actually a really nice study here, and I'm going to see if, not sure if the, yeah, it does work. Yeah, here we go. Okay, so this is, so if we look at this figure, it's looking at the association between no versus any muscle strengthening activity. So let's start with all-cause mortality. So that's all cause of death. Let's look at heart disease, cancer, and diabetes. So what we want to see is, this is a forest plot chart. We want to see everything to that left side of your screen, right? Overall, so look at this diamond shape for everything. Now this is exercise. So exercise reduces all-cause mortality, so reduces the overall risk of death, reduces the overall risk of heart disease, reduces the overall risk of cancer, and reduces the overall risk of diabetes. We do not have any medication that does that. That is how important the right kind of exercise is, okay? Great, so last time I gave this talk, Neil made me do this because he put a slide on what he does, and he said, Tash, you better do it if I'm doing it. So I said, all right. So I thought I'm going to put it here purely to show that the reason I do what I do is because A, I love it. I feel and I see the difference. For me, it's based around my tennis. So I put my tennis in the middle, and what I do, because you need to have purpose, and this is what we were talking about earlier, is you have purpose, then you know, right, why am I doing this? So the strength work is based on building my endurance for my tennis and injury prevention. I want to be able to recover quickly, because at times I'm playing 3-4 matches back to back, plus I'm working more than full time and doing my NHS work and then some, and I need to be able to be on the ball for things. And then also testing my endurance, so that VO2 max. Do I like to run? No, I don't. Can I run? Yes, I can, but I get very, very bored, so I stop. But it's the best way to really get that VO2 max and get that tested. I don't like to hear, nobody needs to hear me scream getting into an ice bath, so I do my own at home. Is it sustainable? No, it is not. And my sister who works in climate change is not happy with me. But my 7-Eleven guy keeps me 2 5-kilo bags of ice, and it goes into my little bath at home. It really helps, especially when I have back-to-back things going on. And gut health, right? So testing, and as I said, I love to run all of these tests because I can then personalize it for my patients. And I call it the Oslo walk and talk. So my social connectedness, where I'm getting my walking in, doing a little boot camp with our Oslo team. And it's just a really nice way to connect outside the office, outside the clinic. So that's something we try and do on a regular basis. So this is how, for me, it's just getting everything together and making it fun, making it worth it, and also making it part of a routine rather than having to go out of my way to do things. Okay, super. Right, take-home messages. Remember, it's personal, ample time, and there's no such thing as right now when it comes to health screening, because it's about staying on top of your health, picking things up before it becomes an issue, and doing something about it. Why do you want to wait until you're sick to actually do something? That's sick health. Medicine 2.0, we're moving ahead. Medicine 3.0 is prevention, right? And picking things up before it becomes an issue. From a hormone therapy point of view, menopause management point of view, hormone therapy is safe and effective. It's there as an option. Don't think that you have to go on it for the sake of going on it. And seek support. So that's a little link for partners as well. It's getting the help and support and opening that conversation and starting that conversation. And here's the resource sort of list as well. So there are a couple of menopause courses, Newson Health, the International Menopause Society as well. And then all these societies have access to free resources plus the lifestyle societies as well. So I'm part of the British Lifestyle Society, Sri Lankan Society, as well as Singaporean. And there are lots of talks and things that you can attend, just whatever you're interested in. And most of these things, it's not paying, it's just registering and showing up, and it's educating yourself. And a couple of go-to podcasts as well, if you're interested to listen to something. Yeah, just learning, right? And it doesn't mean everyone has to do the same thing, but it's just going, right, I found this bit of this talk interesting, I'm going to do a little bit of learning about it. And then pay it forward. Super. So this is our clinic at Osler Health. So a couple of clinics, and really, you know, I'm in a lucky position to be able to work with colleagues where we work together. And it's really thinking outside the box, because at the end of the day, we want the best for our patients, and that's the beauty of it. Any questions? I'll go back to the menopause, to the resource sheet if anybody wants to see that. But yeah, please, any questions? Lots of talk in there. I could go on for hours.
Will you be able to send the presentation?
We don't, but we actually have a resource, a sheet that will get sent. Yeah. So this is sort of our work. So what I've done is I've actually created an actual document which we share, which has everything you need. Yeah. Yeah. But we'll send that across. Yeah. I think we did that. Where's Warren? Yeah, I think we did that. Yeah, we've done that before as well. So that's fine. Yeah.
Is it the myth that HRT causes weight gain?
Yes. Right? And I say that with confidence because there's no evidence. However, fluid retention, especially in hot countries, works differently. So in some women, especially the progesterone component, you may retain a little bit of extra water until the body goes, okay, now I know what I'm getting hormones-wise, and it settles. Yeah. So there is no, and again, same with the Mirena coil. A lot of women say, oh, but the Mirena coil, you end up gaining weight. Actually, there's no evidence for it, but each person is different. So we have to go with that individual. Yeah. But it's giving things time. Yeah. Any other questions? Yes, please. Hi.
I don't really know how to put it as a question. What I found is that since the start of this year, I first found out I had a broken rectum, and from there everything just went downhill.
Oh, I'm sorry. Yeah.
What I have now is, you mentioned aches, pains in the joint. But what I have now is my hands tend to swell, but there's no real pain.
Yeah.
So I'm a bit, is it related to the perimenopause thing? Because I think I'm definitely going through it.
Yeah.
Because I had my period 3 in a row in a space of like 7 weeks.
Yeah.
And then after that 6
Nothing.
weeks of nothing, and then 2 nothing.
Yeah. Yeah. Yeah.
Yeah, but the concern I have really is swelling.
Yeah.
And it's really in my hands.
Yeah, absolutely. And this is the tricky part is, yes, from a period point of view, and I don't know any of the history, but absolutely could be part of the perimenopause. But it's also making sure we rule out other organic causes. So checking your thyroid function, your vitamin D, making sure you're not anemic, see if there's any inflammation in the body. So that part is really important. It's not just assuming that this is perimenopause. Chances are it's absolutely playing a part, but it's looking overall at your health and well-being. Yeah.
High levels of
Yeah. Wasn't there before.
started about 10 years ago. I tore my rotator cuff,
Yeah.
and then thankfully it was not so severe, but it was bad.
Yeah.
Then after that, my whole left hand was,
Yeah.
and essentially now the issue is like mostly swelling, aches, pains, fatigue,
Yeah.
sometimes a bit of dizziness.
Yeah.
Basically, we show the
Yeah. 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 Sorry. Lots of tick boxes there. As I said, it's always looking at the overall picture. Don't just assume things, as I mentioned in my example as well. It's going, this is that perfect time to get a full health screen done so you can check through things, make sure you're up to date with your screenings, your breast screening, your smear tests, your cervical screening, get a baseline bone density scan, American guidelines are 45, this part of the world 50 when it comes to colonoscopy as well. So it's again picking things up before it becomes an issue.
So basically, now I have to go to my company workplace and say, give me the full box.
Correct. Yeah. Yeah. And fight it. Make sure that you get that cover and get it done. Rule those things out and then find the right doctor for you to get the help you need. Yeah.
I actually have to go for surgery first for remove my tonsils.
Tonsils. Okay. Yeah.
So I'm wondering if maybe that is also part of the problem.
We have to sit and look at it overall. Yeah. But just think lots of ice cream. Post. No. Oh, you already got that sorted.
What would it be for almost 2 years to just drop 10 kilos?
Congratulations. It is not easy. Yeah. That's a huge amount. Well done.
No, I
Yeah.
purposely deliberately, I think our Shawners
Mm.
deliberately said slow but steady.
100%. It's about what's sustainable. That's why these fad diets, low carbs, ketos, it just not as we get older, right? Things we could do in our 20s, it just doesn't apply anymore. Yeah.
I forget I'm coming to 50.
It's okay. Told you. You may age, but you never get older. Yeah? Any other questions?
How do you deal with skin problem for menopause?
What do you mean by skin problems? What have you noticed? Or what do you...
Okay, I self-confirm that I'm menopause with 2 cycle tests.
Yeah.
I noticed that the skin starts to wrinkle up and dries out.
Correct, yeah.
It doesn't itch, but at one point or so back, the neck becomes sketchy. Then I realized, oh,
Yeah.
I'm in trouble. So I started to take HRT and it works like magic. But I stopped because few doctors have like they say we don't sell anymore. You should stop taking it.
Oh, I'm sorry that happened.
Yeah, so
Yeah, it's frustrating.
it's frustrating. So I
Yeah.
stopped HRT. But the skin problem, the dryness comes
Yeah,
back.
yeah.
How do you manage this without HRT?
So looking at it from a nutrition point of view, so you can get a lot of phytoestrogens through your nutrition, so your tofu, tempeh, edamame, soy products. Yeah, yeah, yeah. Your strength work, hydration, so making sure you're drinking enough water, optimizing your protein, and moisturizing the skin. So a good emollient. This isn't about spending hundreds of dollars on skin products. It's basic emollients, your E45s, your Cetrabans, your Avenos, head to toe. Just get it on your skin a couple of times a day. Makes a huge difference. But that root cause issue is estrogen. Estrogen, collagen. What do we need collagen for? Skin, hair, tissue, nails. So similar with the estrogen side of things. But it doesn't mean that you have to just go back on the hormone therapy for the skin side of things. There are lots of little things you can put together.
HRT just made my skin looks very nice.
Absolutely, yeah, because the estrogen plays a marvelous role to your skin. We just can't use it for that reason. Sorry. Pleasure. Any other? Yeah.
Sorry.
Yeah.
Something similar to what she's saying. I mean, I've been getting like hives and food sensitivities from food that I've been eating like throughout my
Fine
life.
for, yeah.
So
Yeah.
it's very odd as well.
Yeah.
But it's
Yeah.
also part of the reason.
Yeah, we're seeing a lot more on the urticaria, food allergies, and the skin allergies. So urticaria, which are the rashes that come up, and it could come down to what's called immune mediated, so the body just reacting. But it's very hard to manage because there's no real test to check. We can rule things out, but it's also, going, oh, you can't have this forever, or you need to be gluten free and dairy free. These are things that are just not sustainable unless you have a true allergy. So then it's looking at the gut health and going, right, how do we feed the gut in the right way to be able to have the right microbiome to break things down? Yeah. Yeah, yeah, it's really, really frustrating. Yeah. Sorry, you had a question.
My mum, my mum went through menopause early. She was
Yeah.
like 38, I think she
Yeah.
said, but I didn't know at the time. She came off. I didn't realise either. She came off HRT back however many years ago. The big massive study,
Mm.
abroad.
Women's health study, yeah.
And so I said to her about, right, there was a lot of symptoms we've been talking about over the summer. I said, well, so why don't you go back onto HRT then? She was like, well, I don't know. Maybe I need to go and speak to my doctor. It's something you can go back on, even though she's not.
Yeah.
And she also had a heart attack 5 years ago.
Yeah.
She's also she's got a lot of issues. She had got no
L4, L5?
well,
Oh.
one of her, I don't know which one it is, but she's had the actual disc removed.
Discectomy,
totally.
yeah.
And so she in chronic pain. She was never referred to a pain clinic,
Yeah.
which NHS failed her
Yeah.
significantly.
Yeah.
So she was on Voltarol, whatever it was, and omeprazole, I think, for
Long time.
Long term.
So the omeprazole and its impact on the bones.
And
Yeah.
so when obviously the heart issue happened, she had to come off it completely, which I didn't know was a thing. She's been on morphine patches and all kinds of stuff. So for her, the hormone side of things,
Correct.
there's no reason for her to not go back on it.
Yeah. So this is where you have to look at it as an individual and the risk versus benefits.
Yeah.
Because technically guidelines are, and especially NHS based, it's symptomatic management. It's privately, you have a lot more leeway. But again, it's the beauty of 3 to 6 months of a trial and see how she feels. But if she's got osteoporosis, then it can be used as part of treatment, because actually I'd say hormone therapy is safer than a bisphosphonate, depending on how it's used. But yeah, so it's looking at how she can optimize her health.
So also with the statins, I think she's on statins
Correct.
for the heart health.
Yeah.
Is there evidence for the potential for hormones rather than having statins?
That's a tricky one, because she's already had a heart attack. She needs to be on secondary prevention. So actually, I know there's a lot of misinformation about statins as well. But statin and metformin are two things that a lot of people do need, and once they're on it, they should stay on it. But for her secondary prevention wise, it's not that if she goes on hormone therapy, she can come off the statin. It's she needs the statin because it will reduce her risk of heart attack in the future. Yeah. But I'm sure she's on a lot of medications, so polypharmacy. So it's how do we get her off some of those medications and what can be done. Yeah. Yeah.
Just going back to the osteoporosis, so my mum's 63. I listened to Dr. Louise Newson and I was like, you need hormones, like you never sleep, like you have chronic insomnia, and there was like the weight gain, lots of other things.
Yeah.
She went to the GP, NHS, no, you're too old, you can't have hormones.
Yeah.
But she has just been diagnosed with osteoporosis. Could she now go back and say, I've been diagnosed, give me the hormones? Like, will it have any leeway on the NHS, or she needs to go private?
No, so this is where for the osteoporosis, she'll be referred to an osteoporosis clinic. That's where she has the conversation.
Right.
But as an NHS GP, again, it's just the way the clinic is paid. So we use what's called QOF and data points, etc. And you have to prescribe within those guidelines, because otherwise you don't have that medical legal cover. So a lot of this will go into secondary care. So a lot of things that I do here is actually done in secondary care. So I'd be a GP with a special interest in women's health, sat in a hospital doing all of this, or in my NHS clinic, but set up in a way that I'm covered to do it as somebody with a special interest in it. So it's called a gypsy. But yeah, so this is where that conversation takes place at the osteoporosis clinic, and even where they can then bring in a gynecologist to have that conversation. Yeah. Yeah, but NHS GP wise, it's tough because you can't, I mean, by the time, like when I go back to do my NHS work, I have 40 patients a day, right? Within 2-3 minutes, you've got to be done because you've got to finish your notes, do the 2 referrals you promised them to do, and then some. Whereas here, I get an hour with a new patient and I get to sit and listen, which is the best part for me, is getting all that information.
Yeah.
That's the difference.
How do you convey all that?
You
information
can't.
in 3-4
No way.
minutes?
Yeah. You can't. You physically can't. Yeah. And you just it's tough because it's finding that doing what you can to the best of your abilities, but you just never, and that's where then as a GP, you build those relationships. It may take actually 4 to 5 visits before, but then it's the waiting times with appointments as well. Yeah.
Actually getting to see a doctor in the UK.
I
is
know,
one
I
of the
know.
best, I think,
Yeah.
from what Mum and Dad say, so,
Yeah. Yeah. Yeah.
do like some of the-
Good. Any other questions? Sorry, I've kept everyone waiting a lot longer. Good. Brilliant. Thank you very much, everyone. Thanks.